growth, adaptation, cellular injury, and cell death. So we'll focus on the basics of pathology in this video. So growth adaptations is going to be the primary focus of our video. What are the basic principles? Before I go upon the ways the body adapts to changes, what are the basic principles? So first thing we need to understand that any organ in the body, any organ, be it heart, kidney, lungs, anything, is in homeostasis with the physiologic stress placed on it, with the physiologic stress placed on it. For example, heart, when the BP increases, what happens? The heart tries to compensate, right? There is a low BP, heart tries to compensate. Accordingly, the heart rate will change. If there's increased blood flow to heart, how will heart manage it? With increased BP, it will undergo hypertrophy, which is it will increase in size, right? This way the organ, the heart, is trying to compensate. So it's always trying to create a balance with the normal physiologic process. So organ is in homeostasis with the physiologic stress placed upon it. An increase, decrease, or change in stress results in growth adaptations, right? So whenever, suppose we'll take the example of heart again, there's change in BP, right? BP increases, decreases, or there's another sort of problem altogether, there will be a different type of growth adaptation. So we'll talk about the various types of growth adaptations in this video. First of all, hyperplasia, and hypertrophy. It's important to understand these two. Now, an increase in stress. We said the stress could be increased, decrease, or change, right? An increase in stress leads to increase in organ size. Right? Increase in stress leads to increase in organ size. How will organ size increase? There are two ways the organ size will increase. By hypertrophy, and by hyperplasia. Right? Hypertrophy and hyperplasia. What is hypertrophy? Hypertrophy leads to increase in cell size. It leads to increase in cell size. Meanwhile, hyperplasia leads to increase in number of cell. So hyperplasia, increase number of cell. Hypertrophy, the cells, number of cells will be same, but they will increase in size. Okay. This here, primarily hypertrophy, that is increase in cell size. How will that occur? How will cell increase in size? There are three ways the cell can increase in size. Whenever hypertrophy occurs, there are three things actually that happens in the cell. First of all, gene activation. The body, the cell is alerted that it has to compensate. So a gene is activated. This causes protein synthesis. Right? And this leads to production of organelles. Again, we'll see an example. There is hypertrophy of skeletal muscles, very common. You know, the people who go to gym, who build muscle, the body is told, the gene is activated, they have to build muscles, right? Body is working out to compensate the stress. There's increased stress on muscles, gene activation is in, more protein is created, right? More protein is created, increase in mitochondria. The organelle here will be increase in mitochondria so that more energy is produced, right? So protein synthesis, it creates more cytoskeleton. So gene is activated, protein synthesis occurs. Protein synthesis causes increase in cytoskeleton of the cell. So, cell can accommodate all organelles, and the production of new organelle, more mitochondria occurs. Meanwhile, hyperplasia involves production of new cells. Increase in number of cells, so new cells. Where do new cells come from? New cells from stem cells. Okay, from stem cells. The cells which have the capacity to produce new cells are known as stem cells. Usually what happens is that hypertrophy and hyperplasia go hand in hand, occur together. Example, Most common example actually, uterus in pregnancy. What happens to uterus in pregnancy? Both hypertrophy, that is increase in cell size, and hyperplasia is seen, right? Now permanent tissues. What are the permanent tissue of the body? There are only 3 permanent tissue. 3 permanent tissue. What are the 3 permanent tissue of the body? Number 1, cardiac myocytes. 2, skeletal muscles. And 3, the nervous system. What happens is that they don't have the capacity to generate new cells, so they don't have stem cells. The only things the cells of this tissue, that is cardiac myocytes, skeletal muscle cells, and nerves, can do is they can undergo hypertrophy. They cannot undergo hyperplasia because there is no stem cell, so new cells will not be produced. So these cells can only undergo hypertrophy. Okay. Now, pathologic hyperplasia. Normally, yes, the body cells undergo hypertrophy, hyperplasia to deal with various kind of stress, increase in stress primarily. These two, hyperplasia and hypertrophy, are dealing with increase in stress. But pathologic hyperplasia, when I talk about pathologic, what do I mean? Pathologic hyperplasia. And interestingly, in Robbins, they are saying hyperplasia is a breeding ground for cancer cells. So what is hyperplasia? Hyperplasia refers to production of new cells from the stem cells. And what is cancer? Cancer is the uncontrolled divisions of cell. So hyperplasia can ultimately lead to cancer. So what is this? Hyperplasia. Most commonly we see endometrial hyperplasia, which can lead to endometrial cancer. What happens? Endometrial hyperplasia occurs. This leads to dysplasia. Now, hyperplasia, what happens is that there is increase in number of cell. Dysplasia is there is increase in nucleus to cytoplasmic ratio. What happens is the ideal it should be 1:4 to 1:6. That's the ratio of the nucleus to cytoplasm, space occupying. Right. This 1:4 and 1:6. N/C ratio is a normal ratio. But if there is variation in this ratio, there's alteration in this ratio, and the cell starts to lose its architecture, then it can lead to dysplasia. Dysplasia will eventually lead to cancer. Now, one MCQ that is very important to note here will be that benign prostatic hyperplasia, BPH, benign prostatic hyperplasia, which is also a type of hyperplasia here, does not have increased risk for prostate cancer. So what we saw here, the endometrial hyperplasia leads to endometrial cancer. Similarly, many types of hyperplasia in the body will lead to cancer. But if BPH occurs in males, very common actually as age progresses, benign prostatic hyperplasia, it does not lead to prostate cancer. It has no association, no linkage with cancer. So this hyperplasia is not a breeding ground for cancer. Secondly, first I talked about hypertrophy and hyperplasia, right? Secondly, I would like to talk about atrophy. What is atrophy? Atrophy refers to decrease in organ size. Now, I just said hyperplasia and hypertrophy are dealing with increase in stress, which leads to increase in organ size. Another thing that can occur to organ is that decrease in stress. All of a sudden, this decrease in stress. How will there be a decrease in stress? There are various ways that the organ size will have reduced stress, which will lead to reduced reduction in size. So various ways there is a decrease in stress. Decrease in stress is due to decrease in hormonal stimulation, disuse atrophy, or decreased nutrient supply to a particular area. All this can lead to decrease in stress, which will ultimately lead to decrease in organ size, right? Now decrease in organ size occurs via two mechanisms. There are two mechanisms at role that causes decrease in organ size. Where we saw there was an increase in cell number, there could be a decrease in cell number, right? What was the increase in cell number? Increase in cell number was production due to new cells from stem cells. What was hyperplasia? Decrease in cell number, how does that occur? It occurs by the process of apoptosis. Their hyperplasia was occurring with the increase that was associated with increase in cell number that dealt with stem cells, and decrease in cell number occurs with apoptosis. It's a mechanism of cell death. And there could be decrease in size. Cell size. Decrease in cell size occurs via two mechanisms. Here, decrease in cell number, apoptosis. Decrease in cell size, first mechanism is ubiquitin. Proteasome dehydration of cytoskeleton. In ubiquitin proteasome degradation, intermediate filaments of the cytoskeleton are tagged. There are various types of filaments. Intermediate filament, they are tagged. How are they tagged? They are identified, or they are tagged or picked up by ubiquitin. Ubiquitin goes and attaches to the cytoskeleton. Which one? Intermediate filament of the cytoskeleton. And what happens is tagged, and then the proteasomes in the cells is made aware that ubiquitin has attached to the intermediate cells, and the ubiquitin attached intermediate filaments are destroyed by proteasomes. So ubiquitin and proteasome work hand in hand together to cause ubiquitin proteasome degradation. The ubiquitin attaches with the intermediate filaments of the cytoskeleton, which tags them, and the proteasome identify these tagged ubiquitin intermediate filaments and destroy this. So proteasome causes destruction, ubiquitin helps in identification. That is one mechanism by which decrease in cell size occurs, right? Because here cytoskeleton is being reduced. Now, another method by decreasing cell size is autophagy. What is autophagy? Autophagy of cellular components involves generation of autophagic vacuoles, right? We have studied this autophagic vacuoles when we talked about lysosomes. So these vacuoles, autophagic vacuoles, fuse with lysosome. Lysosomes have hydrolytic enzyme which break down the cellular components. So by mechanism by which cellular components are consumed is autophagy. Increase in cell number was hyperplasia, and increase in cell size was hypertrophy. That was hyperplasia and hypertrophy. We talked about this mechanism which was associated with increase in stress. Then we said decrease in stress is also a change in physiologic phenomena. So we said decrease in cell size is known as atrophy. The decrease in stress occurs which can be due to decreased hormonal stimulation diffuse or decreased nutrient supply to a particular part of cell body tissue. Now decrease in cell number and decrease in cell size are the two ways by which decrease in organ size occurs. So decrease in cell size is associated with two things: ubiquitin proteasome degradation of cytoskeleton and autophagy, and decrease in cell number is associated with apoptosis. Okay, so we talked about hypertrophy, hyperplasia, atrophy, and now we'll talk about metaplasia, change. We said three types of stress occurs, right? Increase in stress, decrease in stress we talked about, and change in stress. The thing we'll like to talk about here is change in stress, that is metaplasia occurs in change in stress. A change in stress on an organ leads to change in cell type. So if there is change in stress, what happens? It leads to change in cell type. Till now, cell was either increased, new cells were produced, the same cell was destroyed. Things happened to that particular cell, but here the cell type is being changed, a change in cell type. This is known as metaplasia. Okay, most commonly involves change of one type of surface epithelium. So most commonly it involves what? Change of one type of surface epithelium, right? What is surface epithelium? When I talk about epithelium, I know you understand. I talk about the top layer of cell. Epi, upar wala, the top layer of cells. So change in the type of surface epithelium. Now it could be squamous epithelium, which lines the surface epithelium, right? Squamous, M-O-U-S. Squamous epithelium, columnar epithelium, or urothelial. Now, squamous can become keratinized, non-keratinized. We know that. Columnar epithelium and urothelial system. It's basically referring to transitional epithelium that is found in urinary bladder. You know how the cells are able to change or stretch out when the urinary bladder is filled. Now, metaplastic cells are better able to handle new stress. What happens is that change in stress occurs. The metaplastic cells, they have metaplasticity property, which enables them to change in type so as to better adapt. Best example of this I can give you is Barrett's esophagus. It's a classic example of metaplasia. What happens in Barrett's esophagus is that you need to understand that esophagus is normally esophagus is lined by non-keratinizing, I'm sorry for the bad writing, non-keratinizing squamous epithelium, right? I said the squamous cells could be keratinized or non-keratinized. So normally esophagus is lined by non-keratinizing squamous epithelium, which is suited to handle friction of food bolus. We chew the food, it goes down, so it attaches, or it moves along the wall of esophagus, it moves along the walls of esophagus. So there's a creation of friction, and normally the esophagus has this non-keratinizing squamous epithelium, which is better enabled to handle the friction of food bolus. What happens in person who has GERD, G-E-R-D, gastroesophageal associated reflux disease, or has gastric problems? The acid reflux from stomach occurs, right? Acid reflux from stomach leads to metaplasia of this non-keratinized squamous epithelium. It leads to metaplasia, and the cells become non-ciliated, mucin producing columnar cells. So we need to understand that what happens, normally we had non-keratinized squamous epithelium, which helped handle the friction. But now the person who has acid reflux, the problem with them is that the food from the stomach is now going to esophagus. There's the coming back of food. The wrong side. So acid reflux. Now the squamous cells would get damaged. So what happens? The cells in the in the esophagus, they undergo metaplasia, and they get converted into non-ciliated mucin producing because acid from stomach could be damaging. So they start producing mucin producing columnar cell. What does this remind us of? This reminds us of intestinal cells. The intestinal cells, they are mucin producing columnar cells, right? They are the ones they deal with acid food that comes from the stomach. So now esophagus is adapted to handle this acid food. So this occurs. How does it occur? There's a reprogramming of stem cells. What happened? There was a reprogramming. The cells are programmed to be squamous, non-keratinizing, right? Epithelium, but they are reprogrammed, right? And they are now producing mucin producing columnar cells, right? Metaplasia is, however, now we are talking about metaplasia in general. This example was of Barrett's esophagus. Metaplasia is reversible. Now I am able to give PPI or other drugs, H2 antagonists. I'm able to give this prostate analogs, so I'm able to treat the GERD in the patient. So the food will no longer enter the esophagus, right? The food will go down the correct pathway. The patient will be free from acidity, GERD, and other stress. So what happens is now body does not require, the esophagus actually, particularly esophagus, doesn't require this non-ciliated mucin producing columnar cells in its area. It can go back to being squamous non-keratinized cells. So it's reversible. So once I treat the patient of acidity, acid reflux, GERD, the patient has normal esophagus once again. Now, under persistent stress, the person is under persistent stress. They do not come to the doctor for treatment of gas. This metaplasia is now able to progress to dysplasia, which we know can eventually lead to cancer. So what I need you to understand is that what we talked about right now, Barrett's esophagus, right? Barrett's esophagus, which we said was example of metaplasia. Now, person with acidity has Barrett's esophagus. They do not come for treatment. It leads to dysplasia, right? Barrett's esophagus itself is an example of metaplasia. It leads to dysplasia. And this leads to adenocarcinoma of esophagus. Adenocarcinoma of esophagus. So, cancer of esophagus occurs. There we said hyperplasia was the ground on basis of which cancer can occur. There I talked about an exception, which was BPH, which is benign prostatic hyperplasia, was a hyperplasia of the prostatic cells, but do not lead to cancer. Here I said metaplasia, change in stress, right? Metaplasia is associated with change in stress, so it is change in cell type. This can progress to dysplasia if untreated in case of any metaplasia. Here we talked about Barrett's esophagus, so it can lead to adenocarcinoma of esophagus. Again, I need you to understand there's an exception to metaplasia also. A notable exception will be your apocrine metaplasia of breast. Again, very common. It has no association with increased risk of cancer of breast. So apocrine metaplasia of breast and BPH, benign prostatic hyperplasia, these two, despite being metaplasia and hyperplasia respectively, are not associated with increased risk of cancer. Next, I would like to talk about vitamin A. Vitamin A deficiency. It can also result in metaplasia. One example I saw was of Barrett's esophagus. Here I will talk about vitamin A deficiency and how it leads to metaplasia. Right? Vitamin A is necessary for differentiation of specialized epithelial surfaces such as the conjunctiva covering the eye. You know how people say vitamin A is important for avoiding night blindness, but similarly it's also important for the proper development of differentiation of conjunctiva covering the eye, and it causes the maturation of immune system cells. So vitamin A has two important roles, one in conjunctiva development of the eye, and another in maturation of immune system, right? Two things, conjunctiva and immune system. In vitamin A deficiency, the thin squamous lining of the conjunctiva undergoes metaplasia. So there is specialized cells, right? It is necessary for vitamin A is necessary for differentiation of specialized epithelial surface cells such as conjunctiva. So with vitamin A, the conjunctiva cells are able to differentiate properly and carry out their normal function. In case of vitamin A deficiency, the conjunctiva cells are not able to differentiate. The thin squamous lining of conjunctiva undergoes metaplasia. So what happens? The thin squamous lining of conjunctiva undergoes metaplasia, and it becomes stratified keratinizing squamous epithelium. So it becomes stratified, multiple layer, keratinizing, thick. When I talk about keratinizing, you need to understand it becomes thick squamous epithelium, right? This whole process, due to vitamin A deficiency, these changes in conjunctiva is known as keratomalacia. keratomalacia. Now, I also talked about here vitamin A playing an important role in immune system development. Now, there's a decrease in vitamin A deficiency. It leads to a problem, that is 1517, chromosome 1517 translocation. I don't know if you've read this, but 1517 translocation is associated with CMN, which is a type of blood cancer. Destruction of vitamin receptor occurs and causes the cell to remain in the blast state. So cells aren't able to be developed. So vitamin A receptor is destroyed. Vitamin A receptor here is destroyed, which is the reason why the blast cells, which are the premature cells, are not able to mature. So they accumulate and the person has an anemia. Here the treatment is very easy. We give ATRA, A-T-R-A. What is ATRA? All trans-retinoic acid. So we talked about vitamin A deficiency. We talked about Barrett's esophagus. Now I'm going to talk about mesenchymal conjunctive tissue and how they undergo metaplasia. So mesenchymal conjunctive tissue. What is mesenchymal tissue? Mesenchymal tissue. These are type of connective tissue. Bone tissue, blood vessel tissue, fat, cartilage, etc. A classic example of mesenchymal connective tissue that undergoes hyperplasia is myositis ossificans, in which connective tissue within the muscle changes to bone during healing after trauma. What happens is trauma, there is a muscle, it starts to become to bone. Now that's a problem, right? The muscle, it becomes bone, it's not able to carry out its function because it becomes hard and difficult to move. So due to trauma, this inflammation of skeletal muscle, metaplasia occurs and production of bone occurs in place of muscles. So metaplasia, it is change in stress, which causes change in cell type. Now we saw 3 examples here. Remember, Barrett's esophagus, very important. Barrett's esophagus, what happens primarily in that? Squamous non-keratinizing epithelium becomes columnar non-ciliated mucin producing, something that resembles intestine epithelium, right? And then we talked about how that is dealt with. We give person some antacid PPIs and person is treated, then metaplasia can be reversed. So it is reversible in nature. Then we talked about another example. We talked about the adenocarcinoma of Barrett's esophagus. That happens when it undergoes dysplasia. And we said again here exception was apocrine metaplasia of breast. Then I talked about vitamin A deficiency. Vitamin A deficiency that is associated with 2 things. First, conjunctiva, second, immune system. Then I said conjunctiva, vitamin A plays an important role in differentiation of the conjunctival tissues. Now this vitamin A deficiency, the thin squamous lining becomes thick and stratified, and that's a problem. It results in this eye problem called keratomalacia. Keratomalacia, keratomalacia. Then I also talked about how it impacts the immune system and can lead to CML due to translocation of 1517, leads to vitamin A receptor destruction, and the treatment for this is ATRA, that is all trans-retinoic acid. Then I talked about mesenchymal connective tissue and how in place of bones there could be place of skeletal muscle there could be a production of bones. An example is myositis ossificans, where muscles become bone, myositis ossificans, after trauma during the process of healing. Now I keep talking about dysplasia. What is dysplasia? Dysplasia is disordered cellular growth. There is no proper way of cell growth, right? In case of dysplasia, I said 1:4, 1:6 is the normal N/C, that is nucleus to cytoplasmic ratio. There's disordered cellular growth. It more often refers to proliferation of pre-cancerous cells. So it leads to cancer. So dysplasia is often referred to as proliferation of precancerous cells, right? For example, cervical intraepithelial neoplasia, CIN. Here the example we will see is CIN, cervical. associated with cervical cancer. Cervical intraepithelial neoplasia, CIN. It represents dysplasia and is a precursor to cervical cancer, and it could lead to CIN 1, 2, 3, which are 3 different types of cervical cancer. We'll read that later. Often arises from long-standing pathologic hyperplasia. So hyperplasia for a long time, or metaplasia for a long time. Pathologic hyperplasia, I said endometrial hyperplasia, right? Or metaplasia for a long time, esophagus. Both can lead to this dysplasia. Metaplasia and hyperplasia. Metaplasia and hyperplasia both can lead to dysplasia. Till dysplasia, the condition is reversible. That is, person will be free from cancer. But if the stress persists, dysplasia can cause cancer. So till dysplasia, it's reversible. Metaplasia is reversible, hyperplasia is reversible, even dysplasia is reversible. But once the cancer is there, is uncontrolled proliferation of the cells. Last thing I would like to discuss before I end is aplasia and hypoplasia. Aplasia and hypoplasia. Aplasia, aplasia refers to failure, absolute failure of cell production. When during embryogenesis. Example would be unilateral renal agenesis. So last I talked about aplasia and hypoplasia. Aplasia, failure of cell production during embryogenesis. So when the body is not able to produce cells in the first place, then we have aplasia. कभी सेल बना ही नहीं. Failure of cell production during embryogenesis. कब पाया जाता है? During embryogenesis. Example will be unilateral renal agenesis. What is hypoplasia? Hypoplasia is what is hypoplasia? It is a decrease in cell production. अभी तक हमने जो बातें की थी, the cell was produced. Then it was either going hyperplasia, metaplasia, dysplasia. But here the cell is not being produced at all, or there is decrease in production in the first place, resulting in relatively small organ. Example of hypoplasia will be streak ovary in Turner syndrome. So there's aplasia, failure of cell production. In embryogenesis, example is unilateral renal agenesis. And then in hypoplasia, there's decrease in cell production during embryogenesis, resulting in relatively small organs. Example is streak ovary in Turner syndrome. Thank you.